I'm a family physician, and I live and work on the traditional territory of Treaty 7. I just want to remind everyone tomorrow is Truth and Reconciliation Day, and to really take advantage of some time to reflect on not only reconciliation, but really understanding the truth of our history. So before we get started, I have the usual routine housekeeping. So as I've said, I am Kathy Scrimshaw. I'm a part-time employee of the Alberta College of Family Physicians, and I also work part-time for the Indigenous Wellness Corps and Alberta Health Services, and I have no other disclosures. Tonight we have a couple of people who are helping technically and logistically, as well as monitoring the chat. Dr. Leah Phillips, Jared Leader, and Salam Bien. They are also paid employees at the Alberta College of Family Physicians. The financial support we receive is from the Alberta College of Family Physicians through a Health Canada Substance Use and Addiction Program contribution. It does not receive in-kind support, and we are presented, this is presented by the Alberta College of Family Physicians. So to capture your attendance, if you can click on the survey link in the chat and enter your name and email. We will be using the chat function to collect questions, and we will be having a dedicated question and answer session at the end of the session. You can also use the raise hand feature to verbally ask a question and unmute. The dedicated time I've already mentioned, and an evaluation survey will be posted in the chat log near the end of the session. And it's really helpful if you do fill out the evaluation so we know what your thoughts are, and especially for information and ideas on further topics. So with no further delay, I'd like to introduce our two speakers. And I noticed Dr. Pereira put in the chat, they're giants in their field, and they are. And so first of all is Dr. Nivez Rasic. She's a pediatric anesthetist and a pain physician. She's the physician lead at the Riddell Pain Program at Alberta Children's Hospital, a clinical associate professor in the Department of Anesthesiology, Perioperative and Pain at the University of Calgary. She's a duly trained FRCPC anesthetist and pain medicine specialist, a clinical associate professor with the Department of Anesthesiology. As I've mentioned, she's the medical lead, and she is responsible for launching one of the first intensive pain rehabilitation programs for adolescents in Canada in 2014. She's a clinician, she's a researcher, she's an educator, she's a strong advocate in pediatric pain. Her clinical work involves providing anesthesia for children of all types of surgeries and procedures, managing acute, complex, and chronic pain in youth. She's also the acute pain lead of the Alberta Pain Strategy. Our second speaker is Dr. Melanie Noel, who is a PhD and registered psychologist, and she's an associate professor of clinical psychology at the University of Calgary, a full member of the Alberta Children's Hospital Research Institute and the Hotchkiss Brain Institute. She directs PEAK, which is a research laboratory within the Riddell Pain and Rehabilitation Center at the Alberta Children's Hospital. Her expertise is on children's memories for pain, co-occurring mental health issues, pediatric chronic pain, and she's published guiding conceptual models of children's pain memory development, co-occurring PTSD and chronic pain and fear avoidance. And you'll see that she has many reviewed papers. In recognition of her contributions to advancing knowledge of the psychological aspects of children's pain, Dr. Noel received an early career awards from the International Association for the Study of Pain, the Canadian Pain Society, the American Pain Society, the Canadian Psychological Association, and the Society of Pediatric Psychology. She was named Avenue Magazine's Calgary's Top 40 Under 40, the class of 2017, a Killam Emerging Research Leader in 2020, and the Killam Memorial Emerging Leader Chair in 2021. Most recently, she was selected for induction into the 2022 Royal Society of Canada's College of New Scholars artists, and scientists. So welcome to these two giants in chronic pain, in children's pain, and I'll turn it over to you, Nivez.
Thanks, Kathy. I'm just going to share my screen here. Perfect. Can you all just see the title page slide?
Looks great.
Okay, perfect. Thank you, Kathy, for that introduction, and thank you to the Collaborative Mentorship Network for the invitation to present. I know I speak for both Melanie and myself. We're always excited to present about pain in children, so thank you. We're going to do a deep dive into this topic over the next 45 minutes or so. These are the objectives we're going to cover during both of our talks. These are my disclosures. I will be talking a little bit about medications that are used in children, and most of those are off-label, as they often are when it comes to medication use in children. So I just want to start by differentiating and talking about both acute and chronic pain. So acute pain is something that virtually all humans experience. It's a very old physiologic mechanism that we have within our bodies, and it's protective. And if you can imagine a child who's playing soccer, who injures his ankle, that results in tissue trauma. And when that tissue trauma happens, it immediately launches an inflammatory cascade within that ankle, which is responsible for healing that ankle. As part of turning on that cascade, the pain system gets turned on, and that's why you immediately feel pain when you have an injury. And pain is protective. It allows that child to protect their ankle until it's healed. Once that ankle is healed, the pain system turns itself off. And this is just sort of a basic anatomy diagram of how pain works. These are the nociceptors at the tissue level. And that information travels along the peripheral nerves. It goes into the dorsal root ganglion, into the spinal cord, crosses over onto the other side, and ultimately travels up to the contralateral somatosensory cortex. And that's really how acute pain works in the body. Now, I want to contrast that with chronic pain. In a similar situation to that child who has an injury to his ankle, you can imagine a scenario where that ankle is healed, but that child continues to experience pain long after the tissues have been repaired. And that really is the difference between acute and chronic pain. And we know that when chronic pain sets in into an individual, there's changes that happen within the nervous system, both the peripheral and the central nervous system, that are characteristic of chronic pain. There's changes that happen with the nociceptors in the periphery. There's changes that happen within the dorsal root ganglion and the spinal cord. There's changes that happen at the interneurons, and there's many changes that also happen in the brain. And this really is sort of the distinction between acute and chronic pain on a physiologic basis. One of the things that we're really interested in the pain world is that transition from acute to chronic pain. We know that there's a significant minority of patients that unfortunately do develop chronic pain, and they undergo this conversion, which is a process where acute pain, unfortunately, these changes happen in the nervous system, and then chronic pain takes a hold. This is a fairly complex process. There's many things that are involved, and our researchers, including Melanie, are working hard to try and figure out what are these important mechanisms. We know that genetics and epigenetics are part of the factors that can promote this conversion. We also know that there are psychological factors that are important, biological factors, underlying disease, trauma, etc., and social factors as well, which all can promote this conversion from acute to chronic pain. There's a lot of work being done in the pain world with neuroimaging. and both acute and chronic pain to try and unravel what's happening in the brain during this conversion. These are some images from Dr. Miller, who is a colleague of mine and Melanie's, who's been imaging children with chronic pain. And we know that as an individual transitions from an acute to a chronic pain state, initially the activation of the brain in acute pain is more superficial, more located within that somatosensory cortex. But as the pain becomes chronic, the processing moves into the deeper areas of the brain more, and there's more emotional neural processing. So other areas such as the amygdala and hippocampus, for example, become involved when chronic pain has taken hold. Oops, sorry. This is the prevalence of chronic pain in adults. So 1 in 5 adults, unfortunately, experiences chronic pain. And this is actually also the prevalence of chronic pain in youth. So 1 in 5 children and youth will have 1 episode of chronic pain by the time they are 19 years old, which is actually really, I think, surprising for a lot of people. And that's really why we refer to chronic pain as an epidemic. Of the 20% of youth that do experience an episode of chronic pain, about 1/3 of these children and youth have an episode that involves severe chronic pain that affects their ability to function. So it affects their ability to engage in schoolwork, normal social development, and physical activity. And when you take these numbers and you apply them to our context in Alberta, we're talking about over 24,000 children between the ages of 10 and 19 who experience an episode of chronic pain. Children do get a variety of chronic pain just like adults do. The 3 most common types of pain that kids get are headache, abdominal pain, and musculoskeletal pain. We also see kids who have pain that comes from nerves, so we call that neuropathic pain. There's also a subset of kids that unfortunately develop chronic pain after surgery, kids that have more of a widespread or whole body type pain picture similar to fibromyalgia. We also see sort of specific pain syndromes such as complex regional pain syndrome. Why does addressing chronic pain in youth matter? I think it matters because the prevalence of chronic pain is really high. There's a lot of suffering and disability associated with it. So chronic pain in youth was already an escalating public health crisis prior to the pandemic. And just like mental health, the rates of chronic pain have risen throughout the pandemic. This is an expensive problem, both direct and indirect healthcare costing about 40 billion Canadian dollars per year. And we know that it's important to intervene early with youth who have chronic pain, as these children have an increased risk of mental health conditions, 2 to 3 times the rate of their peers. They have an increased rate of opioid use problems and socioeconomic disparities, which continue into adulthood. The biopsychosocial model is the one that's most widely accepted when we talk about pain. And this is really just a simple Venn diagram, which depicts that pain is really a combination of biological factors, psychological factors, and social factors. And I think where this Venn diagram intersects, that's really the culmination of that child or youth's pain experience. Oftentimes when I see children in the pain clinic, it says on the referral that these children have pain, which is true. But when you start to do a bit of a more thorough assessment and a deep dive into what these children are going through, you start to see that there's a lot of things that are lurking under the surface of the water, much like an iceberg. And so what we often see with these kids is that oftentimes there's anxiety, depression, trauma symptoms, PTSD. There's often family conflict or dysfunction. A lot of these kids have a hard time at school. Some of them, unfortunately, have been exposed to bullying. There's school avoidant behavior that happens. Sometimes there's substance use as well. Invariably, a lot of these kids are at risk of having physical inactivity, too much screen time. All of this results in poor sleep. And so really there's a lot of these factors with these children. They're all contributing significantly to their pain presentation. When we look at psychological factors, specifically, there is a really close linkage, which Melanie's going to talk about in more depth. But there's a really strong linkage between psychological factors that contribute to pain. Anxiety, we know, is a very strong factor. Depression, PTSD and trauma symptoms, and catastrophizing. And in fact, when we look at children with chronic pain, almost half of them have a comorbid internalizing mental health disorder, which can be diagnosed through DSM-5. And when we do see this comorbid mental health condition in these kids, we do recommend co-treating for both the pain condition and the mental health condition. So what about the parents of these kids? What parental factors contribute to these children's pain experience and pain presentation? We know that children of parents with chronic pain have poor outcomes in pain, health, psychological, and family functioning. We do see a fair number of parents that have an anxious parenting style, and this leads to children who also have anxiety and risk aversion. We also see many children who have social anxiety, and unfortunately, a lot of times, unknowingly, parents facilitate some of this avoidant behavior, which just in general makes the social anxiety worse. And through Melanie's research, she found that the single biggest predictor for the development of chronic pain in children having spine surgery for scoliosis correction was actually parental catastrophizing. And this risk factor was stronger than any of the other risk factors they looked at within that pre-surgical and surgical time. I'm just going to go through a typical case that we would typically see in our clinic. Abby is a 16-year-old girl who presented with back pain. And she had a fall about a year ago while she was at dance practice. At the time, the pain was quite significant. She went to the emergency department, but she was medically cleared. She used to be quite an avid dancer, but stopped dancing about 6 months ago due to pain, which has progressively increased over time. Prior to this injury, she was healthy. She currently takes Advil and Tylenol PRN, but it's not particularly effective for her. The pain is really starting to affect her life, and she's starting to miss school. Her academics in grade 11 are starting to slip. She's limiting her activities, withdrawing socially, and she's very anxious. When you examine her back, you notice that there's some allodynia along the lower spine and paraspinal muscles. There's some tenderness to palpation in that same area, decreased spinal range of motion, but the rest of the exam is within normal limits. The X-ray of her spine is normal. So if we just focus on Abby specifically, if I see a child like this, I'm always running through a differential diagnosis. And in this case, the things that would pop to mind for me would be, musculoskeletal causes of back pain in this population, something like spondylolisthesis or spondylolysis, disc problem, soft tissue injury, scoliosis, other kind of trauma or injury to the back, some underlying rheumatologic condition, something more sinister, tumor, infection, or could this be chronic pain? And in this case, since this is a chronic pain talk, her most likely diagnosis is chronic primary pain. And what about the treatment approach? I'm going to get into this just in a few slides. In January of 2021, published in our most notable pain journal, Pain. This was the moment in time that chronic pain became its own disease. So prior to this, pain was always a symptom of another underlying disease. But at this point, with this series of publications, chronic pain became its own disease. And here, just in the abstract, the way it's defined is that chronic primary pain is chosen when pain has persisted for more than 3 months and is associated with significant emotional distress and or functional disability, and the pain is not better accounted for by another condition. And this really kind of was the recognition that pain, chronic pain, in fact, is a disease of the nervous system, and it's a disease just like diabetes or hypertension or arthritis. This was an article that I found recently. It was published in the Journal of Primary Care and Community Health last year. And it's just talking about diagnosis and treatment of chronic pain. And I'm just going to read the abstract because I think it resonated with me when I read it. The diagnosis, treatment, and management of chronic pain is complex, nuanced, and challenging in primary care settings. These challenges often give rise to internal provider conflicts around appropriate management strategies, perhaps avoiding diagnosis altogether. Factors that contribute to internal provider conflict include knowledge, responsibility, and uncertainties surrounding chronic pain management. This piece acknowledges the complexity and competing priorities of chronic pain management from a provider perspective. We advocate for coordinated and committed care of patients with chronic pain and a sense of shared responsibility among providers to adequately address patient needs. And I think when you read this article, the thing that really resonates is that, you know, in many cases, the most important treatment for chronic pain is giving that diagnosis of chronic pain, followed up with an explanation of that diagnosis that makes sense to that individual. And because chronic pain is complex and nuanced and sometimes difficult to understand and explain to patients, this is an editorial that was written almost 10 years ago, but I think it still rings true that sometimes when you're talking about something that complicated, using analogy and metaphor, especially when you're talking to children, can be really helpful in having them better understand their condition. And this is one of the metaphors that we use often in chronic pain to describe chronic pain to children and their families. And we say that chronic pain is like a car alarm at 3 o'clock in the morning. You have a car and there's a thief who wants to steal the car. And all of a sudden the car alarm goes off and the thief runs away and he's long gone, but the car alarm continues to go on. And one household gets up and then another household gets up, and then next thing you know, the whole block is up and the car alarm is still going on, but the thief has long since left. And chronic pain is a lot like that. It's like that car alarm that just won't stop alarming, even though the threat is long gone. And so sometimes when we use this analogy, this really resonates with children and their families to try and understand chronic pain. So how do we treat this? How do we treat this car alarm? Oops. Just like we use the biopsychosocial model to model chronic pain, I also use this model to talk about treatment with children and their families. And you know, I think one day perhaps we'll get to the point where there will be one pill that I can give to patients to turn off this complex chronic pain process that's going on in their nervous system. But unfortunately, we don't have that. So what we're left with is trying to use a multi-pronged, multimodal approach to treat this complex problem and retrain the nervous system essentially. So I think for each patient, what are the biological treatments that I can offer? What are the psychological treatments? And what are the social treatments that I can offer? From a biological standpoint, I'm going to talk a little bit about medications and interventions. Graded physical activity is very important in chronic pain. And in some cases, kids do need physical therapy to get back up and on their way and improve their physical function. From a psychology perspective, there are actually a large number of evidence-based psychological tools that can be used. Some of them are web-based. There's also, some kids do need therapy from a psychologist who's trained in this area to try and give them more tools to be able to manage their chronic pain. And from a social perspective, trying to reintegrate the child back into school and the academic environment, back into the family environment and their activities is really important in a graded fashion. Letting them know that improving their physical function, even though they have pain, it's not resulting in any kind of damage or tissue trauma. And then supporting the parents through this process. It's actually, it's very difficult to parent a child with chronic pain because it goes against your basic instincts. Your child has pain, but you're asking them to do all of these things that in the short term may actually increase their pain. From a medication standpoint, I do prescribe medication, which I'll discuss in a moment. I also prescribe actually quite a lot of creams for kids. A lot of them are compounded with various things such as anti-inflammatories, ketamine, lidocaine, etc., depending on the situation. I occasionally do interventions on these kids, but really there's actually not a lot of evidence for blocks in children in chronic pain. From a medication perspective, I do think of this from a pharmacologic and physiologic perspective. If I examine the child and I think there's still a component of inflammation or inflammatory pain, I tend to prescribe NSAIDs. With that, also sometimes I prescribe COX-2 inhibitors such as Celebrex, and I'll give them a trial to try and settle down any inflammation that's going on. By the time they come to my clinic, most kids have tried acetaminophen already. For kids that have certain kinds of, especially widespread pain, for example, I will prescribe gabapentin and pregabalin, have pretty good results with that. Kids that present with more neuropathic pain or neuropathic features, typically I'll prescribe various anti-epileptic drugs. My go-to is oxcarbazepine, but I've also prescribed topiramate or lamotrigine in certain circumstances, as well as tricyclics for kids. And then if there is evidence of anxiety or depression, co-treating with SSRIs can be very helpful in many situations. I do get lots of questions about cannabinoids. These are the 4 indications for cannabinoids: neuropathic pain, chemotherapy-induced nausea and vomiting, palliative cancer pain, and refractory spasticity from MS or spinal cord injury. I do find these types of cannabinoids to be effective for refractory nausea, less so for pain in my experience. Obviously, there's lots of kids who take their own supply of cannabinoids. I find when I do ask these kids about it, it's not that it's particularly effective for the pain, but it definitely does make them care less about their pain. And just to wrap up and turn it over to Melanie, I think there's, a few things that really could make a huge difference when you're seeing these kids with chronic pain that could really try and help move them in the right direction towards improved function. Validating that their pain is real and that you can see that they're suffering is important, but also acknowledging that, your pain, as bad as it is, it doesn't represent a bad underlying disease. And I often say, there's not a bad disease, there's not ongoing damage, there's nothing sinister going on here. And following that up with a diagnosis, if that diagnosis is chronic pain, and an explanation that resonates with that youth or child and their parents. Also, acknowledging that the diagnosis is chronic pain, there's no need for further investigation or consultations. All other reasonable items on the differential have been ruled out, and this is what the diagnosis is. Letting them know that your pain is treatable, but you need to take a long-term perspective. We are generally not the quick fix clinic. And as part of that management, taking a rehabilitative approach, that you need to get moving again and take an active role in pain management is important. And in the end, your toolbox will be full of more tools that you'll be able to use, not just for this episode of chronic pain, but hopefully the rest of your life. And then if you come across cases that are more complex, please, do not hesitate to refer to the Alberta Children's Hospital in Calgary or the Stollery Pain Clinic in Edmonton. I think in terms of questions, I think we're probably going to leave it until Melanie's done, if that's okay. Melanie, I'm going to turn over to you.
Okay, thank you, Nivez. Just give me 1 sec to queue up my slides. I had them queued up before. I'll just do it quickly now. Yeah, thank you so much for inviting me to talk with you today. It's really cool to share the stage, the virtual stage, with a very dear friend and colleague and someone who has been really instrumental, not just in my career, but in really launching Alberta as a real hub and a growing hub for pediatric pain research and care. And I want to acknowledge the president of the Canadian Pain Society, John Pereira, who is also here. So Alberta is really representing on the pain stage. And I have so much pride, to be here and to launch my career and to live here and build my family here. So thank you for having me. I think Nivez did a great job of setting the stage of what chronic pain is, its prevalence. And I love Nivez because she really emphasizes not just sort of a biomedical approach, but the importance of the broader systems and, psychological factors. And I think that's really, really important when we think about pain. So I am a psychologist. The field of pain was really founded by this marriage between anesthesia and psychology. But I have to say, I think family physicians and teachers are probably the most powerful prevention agents in this whole thing. So when a child has pain, you're the first to see them, right? The teacher's the first to see them. So I'm really passionate about, collaborating, working with these sort of first points of contact, because ultimately we want to get to these kids and these adults before this becomes a really entrenched problem. Because as Nivez knows, the average time for a child who reaches the Alberta Children's Hospital is 4 years. So they've been living with this for 4 years and going through diagnostic test after diagnostic test. So I think there's a real potential here, and maybe Alberta could be leaders in that regard. So what does this whole topic have to do with this little baby? A big area of my research is all about how children remember painful experiences. We know from the pioneering work of Anna Taddeo in Toronto and some other colleagues that how a baby, even in the first few days of life, experiences acute pain can have a long-lasting impact on how they experience pain throughout the rest of their life. It can also change their brain development. And that was actually seminal research conducted by Jill Vanal, who's also here at the University of Calgary and who we work closely with. But 40 years ago, I'm 41. When I was born in 1981, if I was born with a congenital heart defect, the doctors would have performed open heart surgery on me without any analgesic. Hard to believe, but a common practice. Why did that happen? Because it was widely believed that babies couldn't feel pain. So I don't consider myself that old. So the field of pediatric pain really is as old as me. So there's a lot we don't know, but a lot that we do know. And we know that pain is remembered. Why is this important? What Nivez is talking about is chronic pain. That tends to emerge at around the time of puberty in adolescence. But what I'm going to be talking about today is not just memory for pain, but how chronic pain co-occurs with mental health issues. And I'm really going to focus on trauma, right? And when we think about PTSD, that's really, it's a memory disorder, isn't it? It's these intrusive memories of the bad things that happen to us. And there's a close connection. So when you see patients who are complaining of pain, not all of them have experienced trauma, but it's a real tight association. And as pain becomes chronic and more entrenched over time, we know that even pain in childhood is a risk factor for the development of PTSD, anxiety, depression, insomnia, and even opioid misuse. I'm going to share some really exciting Alberta-born data with you today, really showing how important it is to nip pain in the bud early, because we're showing that pain is actually predicting first onset suicidality, depression, even in children. Okay, so what I'm also going to talk about, this tight connection between trauma and pain, but also I want to raise a compelling notion that the trauma or adversity that your parent had as a child may actually confer risk for the development of pain in their offspring or their children before that child is even born. So Nivez set the stage. I won't belabor it. 1 in 5 kids has pain. That's worldwide prevalence rates in epidemiological studies. It's a huge public health problem. It's been coined a modern public health disaster. The rates, unfortunately, are rising. The pandemic hasn't helped with that. We know this costs about $19 billion a year in USD and can really rob children of a normal development, right? It can also rob families of a normal family development. But the compelling evidence in the last 10 years or so, we've been following these kids over time and understanding what happens to them when they grow up. So we know 2/3 of kids who develop chronic pain, right? These are things like headaches, stomach aches, musculoskeletal pain. 2/3 of them will become adults with chronic pain if they don't receive treatment that works. We also know that even if we get on top of the pain problem, right, and this is the connection between mental health, they are at risk for developing psychopathology into adulthood. And we showed with nationally representative data out of the United States that chronic pain in and of itself is a risk factor for the lifetime course of PTSD, anxiety, and depression. So I hope I'm preaching to the choir. But pain is important and it should be assessed at every visit. So I got interested in trauma because I was interested in memory for pain. And I thought, well, what about when memory goes wrong? And it had been known for decades, right, that there's this tight association and high co-occurrence between PTSD and chronic pain. And when I thought about this, I thought about, a veteran, right? Someone in combat who had a painful traumatic injury that then the pain reminded them of the traumatic event and the traumatic event reminded them, caused more pain. But we thought, what's happening in kids? So we did a simple study. We followed a group of kids with chronic pain and compared them to a group of kids who didn't have chronic pain. And we asked them about their PTSD and look at the differences here. So about 1/3, this is out of Seattle, 1/3 of the kids with chronic pain were experiencing clinically elevated PTSD symptoms. That means they would have met criteria for PTSD. So very conservative DSM diagnoses compared to 8% of kids without chronic pain. And their parents were having these elevated PTSD symptoms too, 16% of the chronic pain group versus 0% of parents in the control group. But what I found really interesting is that when you asked the kids, what was your worst event? What was the trauma that you're experiencing symptoms about? Very few said it was about their pain problem. They were saying things like someone died or, medical trauma. That's another thing we don't talk about a lot, but that's a real source of PTSD. It's not just about the pain. It's not just about painful injuries. Other things like emotional traumas are actually linked to chronic pain. So we are interested in how early life trauma may heighten risk for the development of chronic pain, right? It's this chicken egg question that's hard to disentangle, but I'm excited to tell you that we're starting to figure this out. I won't bore you because you're not a psychologist. Psychologists love complex models. But I will say that we know that if you look to the PTSD or trauma literature and you look to the chronic pain literature, a lot of the same culprits that we propose are to blame for why chronic pain develops and why PTSD develops. They're the same. So things like depression. Nivez talked about sleep disturbances. I'm going to present some really compelling data showing you that insomnia can really drive and exacerbate pain as well as PTSD. We know there's a neurobiological context here. We have colleagues here in Calgary, like Jill Vinal, who's looking at that. What happens to the brain when someone experiences a trauma is kind of similar to what happens to the brain as pain becomes chronic. And again, Nivez, thank you for talking about parents. You have got to think about parents and caregivers in the social environment when you're thinking about pain. So we know that how parents respond to a trauma can influence how a child responds to trauma and vice versa. This overprotective parenting responses can be really inadvertently well-intentioned, but can actually exacerbate pain. But we are learning, and if there's one key message, if a parent has a mental health issue or a chronic pain problem, it's very likely that their child could also have that. Now, I want to tell you, spoiler alert, I'm going to end on a really positive note because we're starting to learn what can actually buffer against this risk. So bear with me. But parents are critical. If I had more time, I'd talk about the neurobiology and I'd bring some of my colleagues up here. Just know that there are epigenetic changes. We have animal studies that we're doing with a colleague in Australia, actually a Calgarian who we lost to Monash University in Melbourne, where we're looking at how trauma in early life can actually turn on and off genes and affect the microbiome and affect inflammatory changes that actually lead to the development of pain. So there's a huge neurobiology here that we have colleagues working on. But I thought today I'd focus more on the modifiable stuff that you could actually talk about and assess in clinical practice. So together with Nivez, in the Virodel program, we followed a group of kids who were seen in tertiary care with chronic pain. And we followed them. We asked them about their pain. So not surprisingly, kids who had higher pain interference, this means they're more disabled by their pain. They're not going to school. It's hard to pay attention. They're not playing with friends. The more disability a kid had, the worse their pain got over time. Not surprising, right? But even holding that constant, even controlling for that, if kids had higher levels of PTSD symptoms when they first showed up at the pain clinic, their pain was getting worse over time. So this is really important. And again, another piece of evidence that we really need to be thinking about mental health and pain, because those two things ping back and forth. Now, PTSD are the symptoms that you experience, right? When you've experienced something bad or a traumatic event. So those are things like re-experiencing intrusive memories, hyperarousal, alterations in cognition and mood, and avoidance. If you have PTSD, you want to avoid any reminder of that bad thing that happened, right? Those are the symptoms. But we're also interested not just in symptoms, but what about adverse childhood experiences? Now, I'm sure many of you know what this is. This is a burgeoning, this area has exploded since the seminal study by Falletti in 1998. But adverse childhood experiences are one of 10 things that could have happened to you as a kid before the age of 18. So this includes physical, emotional, and sexual abuse, physical and emotional neglect, and 5 types of household dysfunction, like a family member having a mental illness, someone in your family that was incarcerated, seeing your mother being treated violently, substance abuse in the home, as well as, surprise, surprise, separation and divorce. Now, this is really important and actually came from family doctors, this whole area of work. This is the famous study, the seminal study by Falletti and colleagues. This was out of an HMO in California, Kaiser Permanente. And they were treating people and doing medical evaluations of adults. And they were noticing this connection between the adults reporting on, oh my gosh, I was sexually abused as a kid and this and that. So they called all of the adults, thousands of people, on the phone and asked them, did one of these events happen to you? Like, how many of these things? It's a yes, no, it's very simple, right? And the findings were unbelievable. For those who had 4 or more ACEs, were more likely to have, 50 plus sexual partners, depression, suicide attempts, like all kinds of mental health issues. Maybe that's not so surprising. But what was surprising was that the more ACEs that the adults had as kids, that was linked to a much higher likelihood of having life-threatening physical health problems like cancer, liver disease, skeletal fractures, and the list goes on and on. And so this study is really important because it's connecting, the environmental insults that happened to you as a kid set the stage for almost every physical and mental health problem that you can imagine. And the more of these that you have, the more likely you are to have mental and physical health problems. Now, listen, again, bear with me. There's resilience here, but this is, I think, really, really important. And there are nuances here in terms of assessment that I'm happy to chat about. There's a whole lot of reasons why adverse childhood experiences can lead to risky behaviors, disrupted neurodevelopment, right? Epigenetic changes. It leads to behavioral issues. It leads to social, emotional issues, right? You're more likely to use substances and engage in risky behavior. That increases likelihood of disease and early death. So there are a lot of reasons, but I think this is really powerful work. So we were interested in, we know that ACEs are linked to chronic pain in adults, but we were one of the first people to kind of ask kids about this, right? So you can see here, we asked the kids who were seen in our clinic at the Alberta Children's Hospital about their ACEs. And you can see that a quarter of them almost are saying that someone in their house has a mental illness. You can see about 1 in 5 have a separated or divorced parent. And then you can see the rates of emotional abuse, physical violence, physical abuse. Now, I want to put this in context, okay? The kids that we see in tertiary care are typically high SES, right? They're typically white. And so there are protective factors. Even the fact that you have to drive as a parent to go to the Alberta Children's Hospital and pay for parking, all that. So I just want to put that in context, and we're still seeing important relationships here, right? But you as family doctors are seeing a much broader range of kids that I would say arguably are maybe more at risk, right, for experiencing these traumas. Not surprisingly, even among the kids that have chronic pain, those with higher levels of ACEs or adverse childhood experiences have lower quality of life, higher depression, and more PTSD. So actually, ACEs, this is not super surprising, but we're even among this group of kids who have been, navigated the system, but are quite, by the time they see Nivez, I mean, many of them are quite, impaired, like disabled by their pain. Even among that group, we're seeing that mental health and trauma and PTSD are really separating the kids that are most at risk among that at-risk sample. Now I'm going to talk about one. I mean, I wish I had a whole day. And if you guys want to do a workshop, like I'm into it. But I'm going to talk about one really important reason why trauma and pain are connected, and that's sleep. Okay. So I took this from like a really cool opinion piece in the New York Times from 2016. You can read that here. It's just a case of someone with severe sleep disturbance and how that was linked to suicidality. And certainly we know that the evidence for this connection between sleep disturbances and insomnia and mental health disturbances is really, really strong and serious. And we know that our kids, we have an epidemic on our hands, not just of chronic pain, but of sleep deprivation. This is increasing. I mean, there are people, I worked in Seattle, there are people that are really trying to get PSAs out there to really advocate for later school start times. I know I'm probably, preaching to the choir, but this is a serious problem. Why? Because at the point of adolescence, there are biological and social changes happening that make that risky. I mean, we all know that, for neurodevelopment and for social, for everything, we don't want any more insults at puberty, at adolescence. So we have a slowed, we have a circadian phase delay. This is the biological stuff. We have a slower rise of sleep pressure, that feeling that gets you closer and closer to wanting to fall asleep. Okay. And yet, the kids need to get up earlier and earlier for school. They have things like smartphones, social media, academic pressures. And so what we're seeing at this juncture from childhood to adolescence, we're seeing that on average, these kids are losing about an hour and a half of sleep. To put that in context, there are really compelling experimental studies showing that a half hour less of sleep leads to emotion dysregulation, cognitive difficulties, academic problems. So this is a serious, serious problem. And I'd be really happy to talk about ways that we can address this and simple ways that we can assess this. And I just want to say, I am happy to share everything. I have really quick, helpful screeners, 7 questions you can get at this. So I'm happy to freely share that with anyone. I won't bore you with the neuroscience, but no, I work with very smart neuroscientists. We published this paper showing this connection, the neurobiological mechanisms that connect sleep and pain. If you take the brain of a child that is sleep deprived or an adult and compare it to the brain of someone who's is having insomnia, there are shared regions that are affected, right? Same with trauma and pain. That's why when we talk about pain or we talk about mental health, we need to be bringing these two things together. And that's a soapbox I'm increasingly getting on. With Nivez, right? If you look at epidemiological studies, okay, big cohort studies following kids from early childhood into adolescence and adulthood, it's been shown that even sleep problems in preschool heightens risk for chronic pain in adolescence. And guess what? We see the same thing with mental health. Sleep problems in childhood is linked to the onset of mental health problems in adulthood. I'm going to share with you a bit of data from, it's not even off the press. Like we just submitted it and we're going to try to get it in the Lancet, fingers crossed. That's really compelling, showing that sleep and pain are the precursors to serious mental health problems. Okay. Back to trauma and pain. Not surprisingly, in the clinic that Nivez runs, right? A fabulous clinic. The kids who come in with more disability, they're more disabled by their pain. It's getting in the way of their life. Their pain is getting worse over time. And these are kids receiving gold standard treatment. Why? Because they have insomnia. Controlling for disability and pain, kids who come into the clinic with higher levels of PTSD symptoms, their pain is getting worse. One key reason is because they're not sleeping. They have insomnia, difficulty falling asleep and staying asleep. And guys, this is really exciting because we have colleagues that have developed 4 to 6 session virtual interventions for insomnia that can actually, help people. So I used to think sleep research was boring, and the data is so compelling now that I think if you had a screener of pain and insomnia, which actually you could assess in less than 1 minute, I promise, if we can get on top of that, we can buffer against the worsening of chronic pain or the development of chronic pain, right? And the worsening of mental health. So this is really encouraging. Now, I've been talking about the kid. What about the parents? What about trauma that happens to a parent, when they were a child? So we asked, there's a long literature showing that there is an intergenerational transmission of pain, trauma. It's tomorrow's, National Day of Truth and Reconciliation. Let's talk about intergenerational trauma. It's a thing. It happens in all communities, but there's also an intergenerational transmission of pain. There are a lot of reasons for that you can see on this slide, and I'm happy to share any resources and slides, but for time, I'll get right to the data. We published this paper 2 years ago, I think. The pandemic has made my sense of time really warped, but we asked parents about traumas or adversities that happened to them as children. Look at the rates here. So these are parents of kids with chronic pain who have navigated the system. These are typically high SES white parents. The rates of mental illness in their house when they grew up, 37%. A third of them, separation, divorce. Okay. But look at the rates of substance use in their house as kids, sexual abuse, 27%, emotional abuse. So we compared this to a community sample, and actually the rates of neglect, were, as for these parents of kids with pain, were higher than the original Falletti study. Now, I'm not blaming parents, and I'm going to tell you how resilient these parents are as well, even in the face of this kind of childhood adversity. And I also want to say, this is not the majority, but it's a sizable minority. So we asked, we thought, if these parents have high levels of childhood trauma, their kids are going to be doing worse. We thought that. We were wrong. So parents that had higher levels of childhood adversity, not surprisingly, they were more likely to have chronic pain and PTSD symptoms. I want to tell you that we have published and shown that in Nivez's clinic, up to 50% of the kids who have chronic pain have a parent with chronic pain. So if that doesn't tell you that there is an intergenerational transmission, I don't know what is. And Katie Burney, a fabulous local researcher here, is really working on this, how to address the intergenerational transmission and really bring care across family members. So that's for another talk, but I just want to plug some of my amazing colleagues. Even though their childhood trauma of the parents, made their mental health worse, we did not find a developmental cascade. So those kids were not doing worse. So I want to say that this was unexpected. I thought if your parent has a lot of trauma, the kid is going to be doing worse. It isn't. And I think this really speaks to resilience among this group of kids, and probably, the work that Nivez and her colleagues are doing to kind of build that resilience. But it's not what we see in animals. So I just want to tell you, long story short, we have animal models where we're looking at epigenetics. If we create, maternal separation or an adversity at birth, we see an increase in chronic pain in those animals because of epigenetic changes. What I love about this is the fact that we have an opportunity to foster resilience in the patients, the human patients that we work with. This is really important. Before I get into resilience, and this is winding, I'm winding down so we can actually get some discussion on the go. I want to talk about some more Alberta data. This is just analyzed. But let me, before you start reading my slide, I'll talk about it first. We were showing that my colleague Daniel Kapala-Sibley at U of C followed a group of kids who were high risk for mental illness. Why are you high risk as a kid? If mom has a history of, a mental health issue like anxiety, depression. And we showed even controlling, following these kids over time, even controlling for mental health symptoms, if that kid had pain, and not even chronic, like I'm talking recurrent, not yet chronic pain, they were at heightened risk for developing first onset suicidality and first onset depressive disorders. And this is really important for us as pain people trying to get pain on the agenda and trying to get people to care, because I think we can all agree that we have a big rising epidemic of mental health in our kids. And if we're showing that pain and sleep, it was insomnia too, are precursors to this, that's given us much more reason to kind of nip pain in the bud, right? On top of this, kids who had higher levels of childhood trauma, they were more likely to develop suicidality, but only if they had pain. Only if they had pain. So this is really, I think, important, why we should assess pain, why we should care about it, and also sleep. Okay, I want to kind of hop on a soapbox for 30 seconds. Bear with me. We've been talking a lot about what happens in the brain, what happens in the body, what you can do as clinicians, right? And that's a whole other talk too. What we can do as parents, but we need to acknowledge in the day before National Day of Truth and Reconciliation that there are other systemic forces that make someone at risk for developing pain, right? Discrimination, poverty, community disruption, right? Misogyny, transphobia, homophobia, all of these things. And so a lot of our colleagues are starting to get together and start to look at and layer on these more broader societal, cultural, social levels of influence that can be sources of adversity and trauma. So we're working on that. I want to give a plug to this commentary. I hope you will read it. It's short. We published it in the Lancet, which is a big win for us, impact factor of 37. But in this article, we're talking about how living a life with chronic pain can be a catalyst for toxic stress, right? That kind of stress that's the most damaging, the most harmful. And really at the core of toxic stress is the absence of protective relationships, right? And stigma and marginalization that can happen, that can really exacerbate. So a life with pain can in and of itself be a source of trauma or adversity, right? And I think as physicians and as providers, teachers, we have an opportunity to sort of be that protective relationship and connect them with community and other resources to really offset this. So again, happy to share it, really proud of this paper. And I think what's great about it is we're starting to go beyond the individual, beyond just the provider and the parent, but into these broader social structures that are important. Okay, I want to end on a positive note. There is resilience. There's stuff that we can do. A lot of people say, well, they already had trauma. Like, what can we do about it? So I want to tell you about this 2 studies quickly. In this study, they looked at ACEs. Okay, they looked at ACEs. They looked at emotional development and depression. But they also asked about positive childhood experiences. Okay, what I'm trying to move you guys, you're in my way. Okay. What are positive childhood experiences? Well, positive childhood experiences are 7 types of things that can happen to you as a child. The ability to talk with family about feelings, feeling the experience that your family was supportive in difficult times, enjoying community traditions, feeling a sense of belonging in high school, feeling supported by friends, having at least 2 non-parent adults who cared about you, and feeling safe and protected at home. That's it. Sounds fluffy, maybe. It's not. What they found was in this sample of 6,000 adults, okay, those who had higher levels of ACEs had worse depression and social functioning, not surprisingly. But the more positive childhood experiences they had experienced, that buffered against, that protected them against the risk that trauma imposed. So what are those experiences? That is social support. That is, facilitating parent-child, communication. This is big brothers, big sisters. I mean, these are the community supports that can really, really make a difference, even in the face of abuse, neglect, and household challenges. Another Alberta study that's amazing followed a group of pregnant women, showed that among pregnant women, those who had higher levels of childhood adversity, when they followed their babies, the baby's HbA axis, their stress response was, exacerbated, but that relationship between maternal childhood trauma and the infant's stress response was buffered against social support. So important, right? How we can link people to community resources and foster this. This is really the antidote. Should we ask about trauma? That is a nuanced discussion. I think it'd be cool to have a session all about trauma-informed care. But I will say that when you ask an adult about childhood trauma, that risks re-traumatization. So I think it's very different to ask a child about something that's ongoing when they're vulnerable and we can be mandated reporters than when you ask an adult. But I don't have time to go into that. But I'd be happy to chat with anyone about that and kind of direct you to some resources on that. The Canadian Pain Task Force that was struck in response to the opioid epidemic, they surveyed people across Canada. I think John Pereira was part of that fabulous, steering committee and group. One of their key recommendations is for violence and trauma-informed pain care. And I really believe that all of us should be learning about and implementing trauma-informed care, and assuming that perhaps all of our patients may have experienced these, and avoiding re-traumatization, learning about the effects of trauma on people, because anyone that works in mental and physical health, there is a connection to what happened as a child and sort of in terms of mental health and environmental stressors. Now, again, different when you're working with kids than adults, but I think it's important for all of us because when we've gone through these experiences, we can be triggered. It influences how we can receive and engage with our providers. And I think this is something that, I'm on sabbatical right now. This is something that I'm really learning about and really want to bring into the pain sphere and health sphere. Okay, I want to thank my lab. I want to thank this wonderful physician there with that beautiful hat. That was on my first day or my first week at Alberta Children's, and I didn't know anyone, and Nivez said, scrub up, we're going to the OR. And she's just been an amazing support to all of us researchers. And hey, we're all in Alberta, so I'm feeling a lot of pride. Thanks for listening. I'm happy to kind of talk about whatever you want to talk about with Nivez. Thanks.
Thanks so much. My video is a bit unstable, so really appreciate these excellent presentations. We do have time for a couple of questions. I guess there's lots of great comments in the chat too, just on just the presentations, the information. I guess one question I have as a family physician, is there some predictors that I should have in my head when I'm seeing patients and recognizing I work rural with a large Indigenous population, and yeah, how do I screen in that situation? And then also from a community perspective, what would you think were the most important things to develop resilience in the population?
Do you want to go, Nivez, first?
And I know Nivez does have to leave right at 8:15, but yeah, so she can go first. Yeah.
Your first part, sorry, Kathy, the first part of the question was
that predictive model. Like we often talk about that transitional pain piece. What should I be paying attention to as a community provider? And what do I need to intervene with?
So specifically, sort of predictive factors for the development of chronic pain?
Exactly.
Or for doing poorly if you have chronic pain?
More that transition. So I've got
okay. Yeah. So I
Who's at
think
risk for that transition?
yeah, so I think some of the stuff that we've sort of talked about, I think the psychological risk factors are the literature is very strong in that area. So, I mean, if we look specifically at, patients having surgery and we say, okay, what are the risk factors for conversion or for development of chronic pain in that time? Psychological risk factors, so anxiety, catastrophizing, less so depression, but still definitely a risk factor. Intensity of acute pain, so very sort of intense episode of acute pain, sort of poor coping in that moment, that would definitely be a risk factor. As Melanie mentioned, trauma symptoms or history of trauma would definitely be a risk factor as well. Family history of, parents that have chronic pain, for example, other mental health conditions within the family, those would be risks for developing. Those are kind of I'm just trying to think in my head, those are really the major risk factors. And also, I think if you start to see very poor function very early on, I think that's also a risk that really they're having a very hard time maintaining function. I start to get very concerned there that decrease in function is going to persist over time.
And so that intervention,
yeah,
promote resilience, would be primarily psychological interventions then.
Yeah, but again, if you're dealing sort of with an acute pain episode, just, kind of, again, looking at that kind of biopsychosocial model and, are there medication therapies that you can offer? I don't use a lot of I barely pull out my triplicate, really, to be honest. But, there are other medications that you can use in the short term to try and get them over the hump with that. So if you're dealing specifically with pain, I would think about some of the medications that I mentioned for sure. And then, yes, addressing the psychological factors, if there is obvious, quite severe anxiety, et cetera, co-treating those conditions, supporting the parents, trying to normalize that experience, letting them know that, this can get better, but we have to work on it, and prioritizing function. Because I find with these kids, as soon as the function starts to drop off, they start missing school 1 day a week, 2 days a week. Next thing you know, they've had 50% school absenteeism. They no longer see their friends, their functions dropped off in all these different areas. It's really hard to claw their way back. Right. So if you can go to school for 4 hours, go to school for 4 hours, and you can build back up to 6 or 7, but really focusing on that function piece, I think is really, really key.
That's great. Thank you so much. There's a couple of questions in the chat. John Pereira asks, just mentions it's a fabulous presentation. Should all pain programs have sleep professionals on site? Can you even have a world-class pain program without that? Should I let Melanie do that one?
I think, John, thank you for the question, as always, asking good questions. I think that all pain programs should have interventions for sleep to address sleep disruption and sleep problems, definitely. So I think, in my world, that is generally the psychologists, and they're, excellently trained in this area, and they do a lot of this work, and we do group programming to deal with some of the sleep issues. So I think that a pain program should be addressing sleep, to answer your question.
And Dr. Noel.
Yeah, I think absolutely. I mean, the data is so compelling. I think, and what we know, I didn't present some of this, for a long time, it was thought sleep and pain are kind of bi-directional, right? You can't sleep, you're in more pain. You're in pain, you can't sleep. That's true. However, what we know now from animal research, from microlongitude, and from really rigorous research is that sleep disruption causes exacerbations in pain, right? We also know that sleep disruption exacerbates, say, PTSD, right? And there's been studies showing that if you treat sleep, you can actually decrease trauma symptoms, right? And so I guess what I'd say is Nivez is in the tertiary care, right? That's so important and really what I love about Nivez is she's open to kind of bringing in new advances and, updating what she says. I will say I work closely with Jennifer Stinson, a researcher in Toronto. We have a couple of CIHR grants where we are developing a portal. So it's virtual care. It's free. It's accessible. We're testing it now. We're also collaborating with people who are making an adult pain portal. And what it is essentially people can come to that, right? It's all virtual care, but it's along a stepped care continuum. So you do an assessment. It kind of says how severe is yours, and we assess sleep. We assess anxiety, depression, substance use, pain. And depending on your level, it pings you to different levels of step care. So at step 1, resources, right? Evidence-based resources. These are the self-help books that help people. Step 2, you get evidence-based, meaning it's been shown to work, cognitive behavior therapy. So psychological interventions for, the issue. If you need more, ping, you're up a level and you get peer support, right? So we're hoping that by creating this, right, for people like for you guys, when you see someone is early on in the game, wouldn't it be great if you could get them into those kind of supports? And if that doesn't work, then, right, then we can go higher. Then we need I hope to put myself out of a job, I never will. We're always going to need psychologists. But you see what I mean, right? The problem is up until now, there's been nothing. So people are navigating the system, and when we study diagnostic uncertainty, they are on this relentless years and years long journey of getting scans and going to the acupuncturists and this. Meanwhile, guess what's happening to their pain and mental health? It's getting worse. So I think, John, absolutely, we got to get on top of sleep. I don't think I guess I want to say, I don't want to put it all in the hands of a sleep professional, because any psychologist can do cognitive behavior therapy for insomnia. Like I was doing it as a grad student, right? And I think there's some people out of Toronto, there's some people out of Seattle who are creating, it's almost ready to roll, virtual care solutions to help people get their sleep under control. And so I just want to say that because I think, you guys are often seeing people at the first onset of issues. And what we need to do is partner together to get some of these, interventions that now by the time they see Nivez, they need something higher, right? They need people like me. But I think there's a huge opportunity for frontline, family care, primary care physicians to kind of ping these to these resources. But it's not going to happen if we don't ask about these things, right? So yeah.
That's great. Thank you. April, if you want to unmute, and I know that Kathy had a question in the chat that Nivez has answered, and then we'll have to wrap up. Although Melanie has nicely said that she'll stay if people want to discuss something more. But April, go ahead.
Sure. Thank you. That was an excellent presentation. During Dr. Noel's presentation, my spidey senses were screaming about obesity. And so when you describe the intergenerational transmission of pain, I really see the analogous example of obesity being intergenerationally transmitted. Has there been any sort of connection or study by yourself that's been accepted and really looks at the co-occurrence of obesity?
Yeah, that's a great question, right? Like there's not been a lot. So I got to say, I'm a pediatric pain person. So I would, if I would have to sort of search the literature to look at obesity and pain, I don't see a lot of it at our conferences. I don't see a lot of publications about it. There's been a couple, right? Of course, physical activity and so obesity, there's so many causes. So, but lots of, most there, the intergenerational transmission underlies many mental and physical health problems, right? But I don't know a lot of research on obesity and pain. I will say that my friend who's a health disparities, health equity researcher said that the original ACEs study, a lot of the individuals were seen for obesity. So there's a connection there. I think it's really important for us to remember that like there are many people with like 7, 8 ACEs that do just fine. So it's not like diagnostic, like if you've had childhood trauma, you're gonna, develop this, or you're definitely going to be obese or something like that. But I would say, April, that's a really cool topic that has been under-examined that I think we should look more into, because I don't know a lot of the literature. I know not obesity, but I know like low physical activity is linked to pain, but I don't know a lot about obesity.
Yeah, I just like what's jumping out at me is the commonality of inflammation with both of them. So thank you very much for that. I appreciate it.
So thank you, everyone. Just want to wind things down. Really appreciate you all joining us. Thank you so much from both our presenters. Lots to think about. I just want to mention upcoming, we do have an echo series on chronic pain that runs alternate Wednesdays. Our next session is October 5th. It runs 4:30 to 5:45, and our next virtual collab forum is on November 24th, where we're looking at innovations in addictions medicine, which will probably involve a lot on ACEs and trauma. So these things are all going hand in hand. If you're not a member of the CMN and want access to some of the events and resources, please take a look at the website. Really appreciate you all for staying and appreciate all your feedback. Please try to fill out the evaluations. Thanks so much. Have a good evening, and thank you again.